The topic is beta blockers in sepsis, which might sound paradoxical, and I must admit that it sounded so for me for a long time. So as mentioned, I come from Poland, currently from Warsaw. These are my conflicts of interest. I hope none of them have any impact on the contents of this talk. So catecholamines are the mainstay of treatment of sepsis and septic shock in particular, and it's without any doubt because they have plenty of actions. We are aware of beta-1 and beta-2 receptors, beta-1 in heart, beta-2 in peripheral circulation predominantly, and this is common knowledge, something that is quite obvious for us, but not so obvious are other so-called pleiotropic actions of catecholamines. For example, the influence of catecholamines on hemostasis or on mesenteric circulation or on inflammatory response, which becomes more and more the issue of interest. If we look at quite recent studies, we can see that, in fact, most of the medication that we use for sepsis and septic shock have influence on inflammatory response, and it's not necessarily the kind of influence that we would like to see in these patients. For example, TNF-alpha is significantly attenuated due to infusion of norepinephrine, and this is not the action of norepinephrine that we have in mind when administering it. The same goes for interleukin-6, and what is even more important is that catecholamines disrupt what is going on not only in vessels or in the heart, but they also impact the oxygen consumption and the ability to produce energy within the cell. As you can see here, the ability to produce ATP and energy is clearly decreased in non-survivors. This is quite obvious. If our cells are unable to produce energy, our chance of surviving will decrease significantly. So look at these differences in the amount of ATP in the parts of muscles that were taken from septic patients that can differ, the survivors and non-survivors. ATP amount was significantly lower in non-survivors' muscles. But look at this, the requirement and the dosage of norepinephrine correlated with the ability to produce energy inside the mitochondria. The larger the amount of norepinephrine was used, the larger was the problem to produce energy in the cell. What is also interesting that in many patients with sepsis, at some point, usually not in the very beginning, but during the course of sepsis, you can observe the sepsis-induced cardiac dysfunction. After initial phase of hyperkinetic circulation, some of these patients, especially non-survivors, enter the cardiac depression phase. And as you can see, the mechanisms are quite complex. One of them is the disruption in the transport of calcium within the muscle cells, but also the ability to produce energy plays an important role in that process. This is about the production of energy, and this is about complex process of calcium transport within the cell of myocardium. And it's not only that, it's also the tendency of catecholamines to increase the risk of arrhythmias, especially tachycardias. For For example, atrial fibrillation significantly increases in severe sepsis and in septic shock, but also the presence or occurrence of atrial fibrillation in these patients significantly increases mortality. What about non-atrial fibrillation tachycardia, for example, sinus tachycardia? What is the impact of tachycardia on cardiac function? As you can see in these patients with septic shock, the increased heart rate was associated with increased left ventricular strain. The wall of left ventricle was becoming stiffer, and it was significantly more prevalent in these patients in whom the preload to left ventricle was increased, and also in whom the heart rate was increased. So increased preload and increased heart rate are risk factors for increasing left ventricular strain and developing lower ability of the heart to fill during between the contractions. Here you can see the effect of the heart rate on LV strain and ejection fraction of the left ventricle, depending on the heart rate. So the question is, perhaps we should do something with that increased heart rate, as it is so harmful. It's not only about heart rate that is so harmful for the heart, it's also about the pro-inflammatory impact of especially prolonged high levels of catecholamines on the myocardium. As you can see in these post-mortem histologic pathologies in myocardium, the stress-induced pathologies, especially inflammatory changes in myocardium, were present in nearly all patients with sepsis and septic shock especially. The maximum epinephrine dose correlated with the extent of this inflammation, but also the time of the catecholamine infusion. So the concentration and the time of catecholamines correlates with inflammation within the heart muscle. Here you can see the picture of the impact of catecholamines or the amount of inflammation within the myocardium. So maybe we could use beta blockers to counteract these harmful effects of catecholamines. As sepsis induces cardiac dysfunction, maybe administration of beta blockade would be helpful in these patients in different pathways. Because on the one hand, catecholamines are compensatory mechanism in sepsis, but also other critical illnesses. But on the other hand, high levels of catecholamines decrease the susceptibility of beta, adrenergic receptors, and have plenty of adverse events in our patients. But which beta blockers should we use? Looking at that slide again, we can see that we probably shouldn't use the beta blockers that act on peripheral circulation, such as beta-2 selective beta blockers. So our choice would be beta-1 selective beta blockers, and something that we really like in ICU are short-acting beta blockers. Short-acting is something that you can stop using in a very short time, and that's why we prefer short-acting medication in ICU in general. And this is one of the most significant early papers on the administration of such a short-acting and beta-1 selective beta blocker in septic shock. That was by Andrea Morelli, published in 2013, with over 150 patients randomized to esmolol or non-esmolol patients. And as you can see in these patients, the decrease in heart rate was quite effective thanks to esmolol. So the doses were high enough, and mean arterial pressure was not decreased. So there were no adverse hemodynamic effects of beta blockers. Stroke volume index even increased slightly, however, that was not statistically significant. The same goes for cardiac index, and the survival in these patients was significantly better. And this was the first signal in reliable study that probably usage of short-acting and beta-selective beta blockers makes sense. Something that is often missed in analysis of this paper compared to other papers is that most of these patients also received levosimendan, which was a combination which might have had an impact on the outcome of the study, which was never replicated again. This is quite recent study, as you can see, published 2 years ago. The STRESS-L study, you can see 126 patients who finally were included in analysis, and this is the characteristics of the study: quite severely ill patients, as you can see by SOFA score in these patients, but the impact on survival or any other clinically significant endpoints was insignificant. So there was no improvement of survival. Another study, quite famous, Landicep, performed also in this part of Europe. Large number of 200 randomized patients, most of whom received landiolol. As you can see, the primary endpoint was achieved, and this was the reduction in heart rate. So it was effective in terms of decrease of heart rate. However, the secondary endpoint, which was survival, was no different in control and study group, irrespective of the time of observation, unfortunately. And there are two meta-analyses of these studies. One of them is this one, published in 24. As you can see, it contained 8 studies, and you can see that there is no significant reduction in mortality between patients who received landiolol and those in the control group. Even if they divided the population between those who had high rate due to sinus tachycardia or atrial fibrillation, there was no significant difference. And this is a very recent paper from January this year. It includes altogether 11 papers with both esmolol and landiolol. And here you can see something that is quite striking: the huge difference between multicenter and monocentric studies, which might suggest that the impact of local clinical practice may be prevalent in these studies and influences the outcome of the study. So it's not the medication that you use, but the bundle of therapy that is used in these patients. And so that was 28-day mortality. This is the longest follow-up mortality. As you can see, more or less the same. Also heart rate, which was significantly lower, but without clear survival benefit or other secondary outcomes, such as norepinephrine dosage, which was not significantly different, or ICU length, for example, or lactic acidosis after 24, 48, 72, or 96 hours, which was not significantly different. They even removed COVID patients to make the population more homogeneous, and also there was no significant. However, now it's close to significance, very, very close to significance. So maybe another study is necessary. There were also trials to use short-acting beta blockers in ECMO. There was a bit different rationale for that. The rationale was to increase oxygen saturation in these patients, to increase the proportion of ECMO blood flow compared to cardiac output. But when you look at that formula that has already been shown by Professor Molnar, you can see that, in fact, the cardiac output is an important part of oxygen delivery formula. So when you decrease cardiac output, you cannot expect nothing else than decreased oxygen delivery. And that's exactly what happened in this physiological observation in VV patients. Most of them are septic anyway. You can see that cardiac output indeed decreased, the saturation increased, which was the goal of administration of beta blockers, but oxygen delivery decreased significantly. So on the one hand, there are adverse effects of catecholamines. On the other hand, these catecholamines have some compensatory effect which we probably should not remove, and we should take this into consideration. So maybe there are some other ways of decreasing the impact of catecholamines, such as using alternatives, for example, and there are plenty of them, not so many used in clinical practice, however, so we don't exactly know where we are. So to conclude, catecholamines obviously are mainstay of compensatory response and our therapy. They have plenty of biological actions, some of them not so obvious and we are not always aware of them. They have severe adverse events, so we might think about using beta blockers, especially short-acting as selective, as a countermeasure, which is effective in terms of reducing heart rate, but probably we should define better the optimal population for this kind of treatment, because differentiation between compensatory mechanism and an adrenergic excess is probably not so easy. Thank you so much.